So I'll be presenting the X files or the atypical presentations of some cases which you see in pediatric retina and a little bit of intraocular oncology also. So coming to retinopathy of prematurity, it's simple, the classification. There are 5 stages. The stage 1 you can see is a demarcation line, and stage 2 is a ridge. Stage 3 is a ridge with an extraretinal fibrovascular proliferation. And this is the stage where if it's with plus disease, you require treatment. If you don't do treatment, it can go for blinding, which is 4A. Fovea is attached, a partial retinal detachment, and 4B when the fovea gets detached. And at this stage, vitrectomy would be only the mode of treatment. And stage 5 is a total folded retina, and it will cause a total complete blindness, which will be unfortunately be irreversible and lifelong. So now coming to this atypical form of ROP is now what is called as the aggressive posterior ROP. And aggressive posterior ROP is what seeing the X-Files, a horror movie. And this is really frightening because of the name itself, because the name it is aggressive, it is posterior. And this is how the face of the retina ROP specialist becomes when they see AP-ROP. So this is a typical case of AP-ROP, the right eye, left eye. And if you think it does not look very scary, you can see the subtle new vessels. These are the shunt vessels which are just proliferating and just causing this AV shunt at just temporal the fovea. And if you are not scared of this, then just see the fundus fluorescent angiography, where you'll be shocked to see that if you think this is the end of the vascularized retina, the fluorescent angiography shows that even the fovea is avascular. And the left eye also, if you think this is where your avascular and the vascular retina ends, you can see that even the fovea. So this is the aggressive posterior ROP, which is beautifully seen in this fundus fluorescent angiography. So AP-ROP is an uncommon, rapidly progressing severe form of ROP described in 2005, and if untreated, it usually progresses 90 to 95% to blindness. And in the developed economies, it usually occurs in extreme preterm babies. And why should it occur in extreme preterm babies? For the simple fact that the blood vessels from the 16 weeks of gestation start growing and reach nasally at 36 weeks, 8 months, and temporally at 40 weeks. So if you have a child who is like a zone 1, aggressive posterior ROP in zone 1, obviously you would think that it's an extreme preterm baby. So this is another case of an AP-ROP, the right eye and the left eye. You can see very immature vessels, and even scary is the fluorescent angiography. We can see there's a total capillary dropout till the disc margins. So obviously you would think that this child has to be extremely preterm, because in zone 1 it should be like 16 weeks or 20 weeks, which is impossible, at least 22, 25 weeks. But this was a child of 33 weeks and 1625 grams. So this is what we are seeing in India and in developed countries about AP-ROP in the big babies, and it is nothing because of the use of unblended oxygen. I thought this was a good forum for the postgraduates to just to sensitize that a very simple preventive measure can actually avoid this blinding disease. And so blended oxygen, so when do the pediatricians in India use blended oxygen? So these are the blenders which come attached to these CPAP machines on ventilators. So this is from 21 degrees to 21% to 100%. And when the child is on these machines, they do well ROP wise. But when prophylactic oxygen is given straight from the central line to the child, it is when this is 100% oxygen unblended, which forms the very harmful form of AP-ROP. So this is what is seen in the mice. This is seen in the animal model in the West, and we are seeing this in humans. So this is a mouse model at 7 days, where the vascularization is mounted and the fluorescence is showing going till the aura. They keep at 70% oxygen for 5 days and 12 days in atmospheric oxygen, and you can see the posterior capillary dropout areas. And this is exactly what we see in our cases in humans here, where this is a child of 33 weeks. They should have been born with vessels at zone 2, almost in zone 3. So this was given unblended oxygen for just for 12 days. And at 22 days, there is a severe form of ROP, which is unfortunately happening in the humans. So although now we have the new treatments, the anti-VEGF injections, and these do extremely well, but we all know is that preventive is better than cure. Why should you cure such disease when these can be prevented? So the take-home message is that 100% oxygen, when the pediatrician asks you, how do we avoid ROP? 100% oxygen should be avoided. oxygen blended with some form of air to be used, and the oxygen saturation should not go beyond 95%. So these are the take-home messages. Now this is an interesting case of again a preterm baby with ROP. This is a twin girl. The left eye we had lasered, and you can see this sort of RP flex there, and we didn't know what was happening, and this was the other twin. So we treated the ROP, but this child also had these flecks there, and we didn't know, so we just ignored it. And what happened after 4 years, the family came back with the next pregnancy with a boy having this fundus pictures. So this was a case of, so we thought let's check the mother. The mother was having the same flex what the girl children was having, the girl twins were having. So this was a case of ocular albinism, which is a X-linked recessive disease, and that's why the males get affected, the boy got affected with just the ocular albinism, and the females, both the twin girls and the mother, were carriers. And this is called as the Nettleship-Flack syndrome, where you will see these flecks there in the girl child. This is a case of a bilateral retinoblastoma, nothing atypical about it, but this is just shows the importance of genetic counseling. We know that a bilateral retinoblastoma is autosomal, recessive. Yeah, it's autosomal dominant, so there's a good chance that the parents might have it. So you must take a history, and we took a history. We examined the mother, and mother had these scars with calcification. So, and we took a history. They said her sister in childhood died of some eye disease, and the mother had these benign form of lesions called as the retinocytomas. So we called back her mother, the grandmother of the child, and we were shocked to see even she was carrying these regressed retinoblastoma. It's called retinocytoma. They never developed the disease, but the child developed the disease. So what was important, what did this, that we did the genetic testing and found out the mutation in the child and the mother. And what did this help? For the next pregnancy, we could offer prenatal diagnosis, and in the fetus was found to be a carrier when the child was not even born at 12 weeks with chorionic venous biopsy, and the family went ahead with the pregnancy. And what we could do, we could start early screening, and at 10 days you can see this small lesions appearing, and we could just treat it with transpupillary thermotherapy and did very well. So this, we could avoid the blindness and avoid the consequences of a advanced retinoblastoma in this child. This is another case which is a unilateral case with an exudate detachment showing this telangiectatic vessels. So what is your first diagnosis in a boy? Yeah, Coats disease. So Coats disease, you can either observe these cases, or in rare cases we do a surgical intervention where they do a subretinal fluid drainage and cryo. But what is important, that there could be a hidden tumor in this. There's a very rare form of retinoblastoma called as the, what are the types of retinoblastomas? The endophytic, exophytic, and the rare one? Diffuse infiltrating type of retinoblastoma. So this also looks like an exudate detachment, and there were a few telangiectatic vessels, and the ultrasound showed like a closed funnel RD with a subretinal fluid. There was no mass, and the MRI gave suggestive of Coats disease. But somehow clinically it was not very conclusive of Coats. We did an enucleation, it turned out to be a retinoblastoma. So this is a rare form of retinoblastoma where you will not see calcification, you may not even see a mass lesion, but you have to just suspect it clinically. This patient was referred to as a central serous chorioretinopathy, a healthy female of around 45 years old, and we saw this yellowish mass which was just superiorly, and the fluorescein angiography showed multifocal, the yellowish mass was there with a very shallow exudate detachment, and there was early block and motile appearance of the FA with no intrinsic circulation. So can you tell me a mass lesion which is not inflammatory, amelanotic, it can be multiple or single, and this is the typical fluorescent angiograph where you see the pinpoint leaks like this. So obviously I'm talking about eye cancers, so this is choroidal metastasis. And this patient was, although healthy and just with the eye symptoms, turned out to be a stage 4 CA cancer, which was spread to the spine. Now, just an interesting thing about choroidal melanomas, clinically they are divided into small, medium and large. The small usually is observation, medium is either you brachytherapy or enucleation, and large is enucleation or brachytherapy. So I'll just show you a video of ocular brachytherapy being done using the iodine 125 seeds on a gold plaque. So these are the seeds being loaded by a physicist who is standing behind a lead bench with a lead glass. And this is how the plaque looks. They put cyanoacrylate glue overnight. Next day, flash autoclaving is done. And this is the surgical steps where you do a conjunctival peritomy and hook all the muscles. And you mark the clock area where the tumor is seen clinically at the limbus, and you mark where you want to put the sutures. This is given by the software, or you can do like a simple, what you do in a buccal surgery, you localize the break, you localize the edges of the tumor, and you mark it, and you put the sutures. And these are partial thickness, making sure you don't rupture the sclera. And this is a dummy plaque, or the cold plaque, which has been placed here. And after securing the sutures and putting temporary knots, you do an indirect ophthalmoscopy to make sure it's covering well, because you don't want to keep a radioactive plaque there and then see that it's not placed correctly. And this is the hot plaque. You remove the cold plaque, and this is the hot plaque with the radioactive seeds, which is placed in the same area where the tumor is, and you make the sutures permanent. And the plaque is kept for around 5 to 7 days for a melanoma, and again you have to go back and remove the plaque. It's subconjunctival, episcleral. So not all small melanomas requires only observation. So this is a mnemonic which is given by the Shields group. It is called as TFSOM UHHD. It's to find small ocular melanomas using helpful hints daily. So if you find a melanoma, a small melanoma, which is thick, which is more than 2 millimeters thickness, having subretinal fluid, the patient is symptomatic, there is orange pigment, and if it's very close to the optic nerve, these are the small melanomas which have a potential to metastasize, and these need to be treated. So this is a case like this, a very small choroidal melanoma which is close to the optic nerve. There is shallow exudative detachment and the patient is symptomatic. So to treat, we have the only options would be like brachytherapy. Now if you put a plaque over this, what's going to happen is that you would aim for very high dose of radiation which will knock out the optic nerve and the fovea also. So what we have done is the transpupillary thermotherapy, which can be utilized only in small melanomas which are very close to the posterior pole. So when you see cases like bilateral active stage 4A, so what do you do with this? You can't operate one eye and wait for 2 weeks and operate the other eye. So what we usually do is do a bilateral simultaneous vitrectomy, taking the risk, telling the patient that there is a small chance of endophthalmitis happening, but that risk is much less than the bilateral blindness, the other eye blindness which can happen. So you want to stop it here? Okay, fine. So there was a short quiz, but I think we have overshot the time. So I would just allow the next speaker who's coming here to take the talk.
Thank you, Dr. Parag, for reciting beautifully the importance of pediatric retina. Since we don't have much time for the question and answer session, I would invite Dr.